This is inverted vitrectomy.
Triple unblock PO for macular pucker, brilliant blue twice stained epiretinal membrane and internal limiting membrane with taut hyaloid. Retinal pictures and angiogram display dragged retinal vessels, vascular tortuosity, and leak due to edema since the early angiogram towards the late phases. The preoperative OCT displays a very thickened retina with a linear epiretinal tissue on the macula and the intraretinal distortions in all retinal layers. The patient is phakic, and this is his left eye. Supratemporal and supranasal sclerotomies were placed, and an inferotemporal infusion line as well. This was an extensive macular pucker all over the macular surface. A wide-angle vitrectomy was started, and we noticed this thick macular pucker over the macular surface. An attempt to grab the hyaloid was not quite fruitful, as it was really attached nasal and temporally. A first air fluid exchange was performed, a complete one. Brilliant blue was used the first time to stain the epiretinal tissues, including the external and internal limiting membranes. An attempt was made to remove the hyaloid, the first membrane on the roll to be dealt with, but it was very taut and stuck, as you see the reflexes of the retina when trying to catch it with the aspiration device. With the internal limiting membrane forceps, the epiretinal tissue was reached, and we chose the very center where the membrane was thickest, as we noticed in the previous OCT, like popping up, giving us an edge, making it less difficult to perform the first peeling. Remember, this is an inverted image, and this is the left eye, and the positions are as follow: supratemporal, inferotemporal, supranasal, and inferonasal. The pucker was detached en bloc, the second tissue that was reached, and it is very interesting to observe its attachments to the internal limiting membrane with high astrocytic proliferation, displaying areas well stained and areas less stained due to gliosis. The technique to remove such adherent membrane is grabbing it well and moving horizontally, avoiding an early tear. In this case, because the adherence was so tight, and you may well observe when the interface of the hyaloid adherences and the ILM becomes whitish, that if you keep pulling on the ILM, it could well tear. So we switched directions, in this way coming to a very good unblocked PO of the epiretinal tissue. Like a tent, the epiretinal tissue was lifted in the mid-vitreous topography area, and you are able to see some stalks coming off the membrane down. These stalks were adhered to the internal limiting membrane very tightly indeed, and now they are loose and hanging, still attached to the epiretinal pucker tissue. A second air fluid exchange was performed, another complete one. That helps stain better the internal limiting membrane when brilliant blue is used for that purpose the second time, since we removed the macular pucker in the previous step of the surgery. The ILM basal membrane of the Miller cells could well be seen now, even though the staining was quite irregular. The ILM was the third tissue reached. Most of the membrane came in a single peel, interrupted by the thickened fibrous full-thickness tissue that crossed obliquely the macula, as we could observe a whitish denuded of internal limiting membrane area on the mac surface. That relieved all central tractions caused by the attachments. The membrane was caught, but because most of it already detached due to its close relation to the posterior hyaloid and previous hyaloid cells present on the surface of the ILM, we now removed remnants of the membrane, especially where it was excessively adhered. This was made due to accomplish the best removal possible of the ILM. Peripheral endolaser was applied at the sclerotomy sites, just in case we could have created a small break on those areas. A third air fluid exchange was then carried out to finish off the surgery. Oftentimes we plan to insert intraocular gas, and that doesn't need to be very much expensive, and because the patient in this specific case is phakic, face down position has a twofold purpose: to flatten the retina even more and to avoid cataract formation. This is the postoperative day 1, the lens very clear, a full gas fill and pretty good looking retina.
Thank you very much for your attention.